I think, Woodrow, the thing is that most people don't realise that any doctor who's got a basic medical degree in Australia can operate and can call themselves a surgeon. And it may mean that that person has done no surgical training at all. The reason why they do it is because that engenders, I suppose, an advantage over their other general practitioners or people who've got basic medical training. The difference between a specialist plastic surgeon and people who haven't done that training is plastic surgery is designed to do two things. One, it's to have a sound understanding of the operation, the blood supply, how to make that operation work reliably and predictably. But also there's an aesthetic component which is integral to training in plastic surgery. So we're not, for example, in doing breast surgery, making the breast smaller. We've got to make the breast smaller and make it look like an attractive aesthetic breast. Yeah, so someone who's a specialist plastic surgeon, in addition to doing basic surgery training, has gone on to do a minimum of 5 or 6 extra years in plastic surgery training. And that's usually done in a combination of major teaching hospitals and also out in private practice as well. And most people, in addition to that, would then go and work overseas for maybe 1 or 2 years in clinics such as the Mayo Clinic or the Cleveland Clinic, where you get the very best and latest techniques and training in what's happening around the world. So you have a rounded, comprehensive understanding of all aspects of plastic surgery. Yeah, so, and in fact APRA are starting to enforce this much more ruthlessly. I think the reason is because they've worked out that most of the public find it incredibly difficult to work out the difference between a cosmetic surgeon and a plastic surgeon, particularly when the cosmetic surgeons often make up names and titles they put after the end of their name. And it means that if you're a consumer, it's almost impossible to work out what's the real deal and what's the imitation. They copy language, they copy titles, they copy training programs, but without actually doing that accredited licensing board. And they only accredit training programs that meet a certain standard or a certain criteria. I suppose a way like that would be getting a driving license. Anyone can drive a car, but you have to pass a certain standard before the government awards you a license or an accreditation. And that's the difference between a cosmetic surgeon and a plastic surgeon. One has the Australian Medical Council license or training, and the other person doesn't. There's two things. If you're thinking about having an operation, you want to, one, achieve your outcome that you're seeking, but you also want to live through that operation and come out the other end healthy, with the result that you expected, were anticipating. And that comes back to two things. It comes back to one, the surgeon and the facility in which he is performing that surgery meeting a set standard of criterion in sterility, in instrumentation, in training of the staff, training of the anaesthetists, training of all the people around. It's a team effort. I work on a number of investigative boards, and almost invariably we see systematically shortcuts being taken either in sterility or in training of staff or follow-up. And one or two of those things might be able to be absorbed by the organisation or the facility, but if you collectively add them up, it means that almost invariably systems start failing and things go wrong. An analogy might be trying to get on a plane and flying from here to London. You're the passenger, you want to arrive at your destination on time, safely, without crashing. But you know to do that, you have to rely upon that particular airline, the pilot, the staff, the crew, the maintenance team, the air traffic controllers. All of those things are integral. And the only way you can really be guaranteed that you're going to get that is if you seek out someone who is a accredited specialist plastic surgeon and works in an accredited licensed hospital, and you can find all those out because they're on their door. Yeah, my specialty has, even though I did general plastic surgery initially and did microsurgery on all parts of the body and operated, from top to toe essentially, my specialty is, and my practice is condensed down to effectively being breast surgery, cosmetic and reconstructive breast surgery and facial aesthetic surgery. And it means that around me I've been able to develop a team of anaesthetists, a team of nurses, and a team of technicians and ward staff who absolutely know just as much as I do about each one of those procedures. It means that you could almost ask my receptionist about the nuances of breast surgery and she'd be able to tell you, simply because that's what she does all the time. It means that patients coming to see us know what they're going to expect, but there's also a team of people around us and the patient, making sure we get the very best outcome. We see a lot of people for second consultations and third consultations, and sometimes after things have gone wrong. So they've had an operation somewhere else and things have gone wrong. And almost in every case, you can trace why it's gone wrong back to that first operation, the preparation before the surgery. It's critically important that you do your homework. So you need to make sure that the person you're seeing is actually a surgeon, that is, that they are a member of the Royal Australasian College of Surgeons. That's easy to find out, you just look them up. You need to make sure they've done the training in the area that you want to have fixed. So all plastic surgeons are specialist plastic surgeons, but some specialise, for example, in hand surgery, some specialise in breast surgery, some specialise in facelifting. It would make sense, therefore, that if you want to have a breast operation, find a plastic surgeon who specialises in breast surgery. If you want to have a hand operation, find a plastic surgeon who specialises in hand surgery. The other thing that's critically important is be aware that there's a lot of imitators out there, a lot of people who haven't done the hard yards, who haven't done the training as we talked about. And they're the people that you need to avoid if you absolutely can. And more often than not, you can get an inkling of that, in that when you go to see them, it's not quite right, it's not quite adding up. So trust your gut instinct, trust what you're seeing, and make sure that you see maybe 2 or 3 people before you embark upon surgery, because even though those 3 people might be presenting you with the same information, they're going to be presenting it to you in a slightly different way, with slightly different emphasis, and it means that you're going to be much more informed, you're going to be much more able to recognise which one of those 3 you get a good relationship with, and it means that you can convey what you're seeking. The most important thing is have a very clear understanding about what you want out of the surgery, what your expectations are. So that, for example, in breast surgery, most people would assume that there is a common ideal breast. In fact, that's not the case. So most people have an individual interpretation about what their ideal breast looks like, but they need to understand that that may be different to their sister or their brother, to their girlfriends, to what they see on social media. And the outcome you want is what's right for you. The target we should be aiming for is what you want, not what you see on social media or not what your girlfriends want, because invariably what ends up happening is 2 or 3 or 4 years down the track, when you get out of the shower and look at your breasts, or when you're getting changed in the change room and you look at your breasts, you want the image coming back at you from the mirror to be the same as what you perceive to be your perfect breast. You don't want to be looking at the breast that your then boyfriend said was the perfect breast. You want what's right for you. What ends up happening is that people have an idea about what they'd like to achieve, what they'd like to get out of the surgery, and then they start doing a bit of investigation and start doing a bit of preliminary homework, maybe through the internet or amongst friends. I'd suggest that you then want to try and supplement, if you can, by going to reputable sites where you know the information you're going to get is going to be balanced and is not going to have a spin on it to try and direct you into a particular way or not. So the Australian Society of Plastic Surgeons is a good site. The American Society of Plastic Surgeons is also a good site. There's lots of podcasts, lots of information which is factually accurate and presents the very latest in what is being seen around the world. So that's a good place to sort of background. And then, as I said, see 2 or 3 people who are leaders in their field in that particular area and go along for a consultation. You don't necessarily need to have surgery with them, but what you're trying to do is you're trying to fill in the blanks. You're trying to make sure that your understanding of what the surgery is, what the risks of that surgery are, and the likely outcome that you can possibly achieve is reasonable, is predictable, and that you can achieve that result. So most implants that were put in since about 2003, 2004 have a lifespan of somewhere between 20 and 25 years. The thing that I suppose that has changed is in the last 2 to 3 years we've been aware of 2 things. We've been aware of a very rare form of blood cancer called anaplastic large cell lymphoma, and we have also been aware that it's associated with a textured implant, and it would appear that in addition to that you need that textured implant to become infected. And that's really important because last year, for example, 87% of all implants put in Australia were textured. So does that mean everyone who had a textured implant is at risk of developing this very rare form of blood cancer? And the answer to that is no. What we would suggest is that if you had an implant put in the last 10 years, more likely than not it's going to be a textured implant. Now, if that implant is giving you absolutely no trouble at all, if it's soft, non-tender, you're feeling well, nothing would make you suspect in any way that anything's gone wrong with that implant, you probably don't need to have that implant removed and replaced. But what I would suggest is we need to investigate that implant to make sure that is the case. So we know that with the recent changes in mammogram, I wouldn't let you have a mammogram if you had a breast implant because of the very high risk of rupturing that implant. They squash the implants very hard now, and we've been at a number of people who've had their implants ruptured by the mammogram. So we can't get you a mammogram, but what I'd suggest we do is we get a MRI scan. What that allows us to do is comprehensively look at your breast, at the implant and the capsule, and if all of that is okay, there's nothing sinister or nothing untoward, and if you're otherwise well, I would simply just leave that implant inside you. And obviously keep an eye on things, check it maybe every 2 years or something like that. Make contact with your surgeon, just confirm that he is happy with how it's all going. But no, you don't need to have that implant removed. And it may well be, as we talked about before, it may well be you might have a good relationship with the surgeon who put your implant in, but alternatively you may have a less than ideal relationship and you may feel uncomfortable about going back to that surgeon. Any plastic surgeon in Australia would be only too happy to see you, to counsel you and give you advice. Almost invariably the first thing they'll suggest is getting an MRI scan, as I said, just to check and make sure things are okay. And as long as everything is okay, then we can simply monitor that conservatively and just keep an eye on how things are going. When you first start out in plastic surgery or in surgery in general, all operations you weight equally in that they all seem to be in the right hands, conducted by the right surgeon, seem to be effective and work, and everyone seems to be happy. And what you learn over time is in fact that's not the case. Even in the very best of hands, there are operations which are either incredibly risky or unpredictable or just don't work. So for example, we know the Brazilian butt lift, even in the best hands, has a risk of somewhere at about 1 in 3,200 of the patient dying. So I would say that that is I would call a dumb operation. Don't do that. There's a very risk associated with that operation. There are other operations like breast reduction surgery that we know almost invariably result in patients who are super happy, who feel it's probably been one of the best things they've ever done, and it makes a tremendous difference in their lifestyle and how they can live their life. So almost everyone with large breasts would complain of back or neck pain, and that makes sense. You've got the weight sitting in the front of your chest and you're continually arching your shoulders back. Most people end up with indentations in the top of their shoulder, and almost at least 50-60% would end up with some sort of rash underneath their breast, particularly in hot weather. You don't need to take a lot of weight off the breast to completely alleviate all of those symptoms, and most people would find within 48 hours that that neck pain, back pain has completely gone, even if you drop down from say 1 or 2 cup sizes. It's one of those operations where consistently and predictably works. So what that means is that we talked about before about with experience, what do you see? You see that when people come in and they're seeking an operation, for example, I'd like to have total body liposuction, we would suggest you could have it, and there's lots of people who will try and sell you that. My suggestion would be, again, that's one of those operations that has lots of unpredictability to it, and more often than not ends up with patients saying, I've paid a lot of money but I haven't got the outcome I expected. So I would be suggesting, no, don't. So hopefully you've got a surgeon who is experienced and who is honest in that what they're trying to do is they're trying to look after you and guide you into safe, predictable operations, not operations that are going to balance out their bank account. We want an ethical, honest approach to how we deal with our patients. And if I just be selfish for a minute, but what I want is I want a patient who comes in that I give them the right advice, I give them open and honest advice. We perform a surgery which is predictable and safe and works, and then we end up at the end of it with a happy patient. And that's because they know what they're getting, they're not overcharged, they get a reliable result, and they're happy with the outcome. If you go to the opposite, which is you're selling a procedure, if you're advocating something which is one of those less than safe or less than predictable operations, and you're doing it because for ulterior motives, then the patient has the surgery, almost invariably the result they get is not what they were promised, so they're angry and pissed off. And they're also saying, well, I didn't expect, had I known this, I would never have done this surgery, which is what I hear all the time on these second and third consultations. And these are patients who've often spent a lot of money. They often didn't realise the surgeon who was treating them wasn't a surgeon. And then they say, well, hang on, I feel maimed and disfigured and I haven't got what I paid for. Can you fix it? And the thing is that those patients will go back to their surgeon who sold them that operation over and over and over again, seeking redress. And what sounded like a great idea as a surgeon promoting an operation which is not a good one ends up biting him big time. And he would just be far better to be open, honest, transparent and ethical. That's surely a much better way to move forward. So the first thing to be careful of with forums is that people writing or answering questions in forums almost invariably have an agenda. There's a reason why they're on the forum. I'm not talking about the patients, I'm talking about the surgeons or the medical practitioners answering the forums. And you may or may not be aware of that agenda when you ask your question. So you need to, I suppose, treat the answers that come back with some skepticism and perhaps with a grain of salt. And it may be what they're saying is true, but it may also be that they're simply trying to sell you an operation. And so that's where it comes back before, what we were saying before is do your homework in that, yes, use the forum as part of your homework, as part of your research, but make sure you fact check what's being said by referencing back to we talked about before, the Australian Society of Plastic Surgeons, or as I said, I remember the American Society of Plastic Surgeons, like an encyclopedic series of podcasts and information and things like that. I'm recognising that America and Australia are different, but what you're doing is if you hear something on a forum that seems to be too good to true, too good to be, if you see something on a forum that's too good to be true, almost invariably it is. So, okay, is that too good? Let me fact check that. And then, as I said before, if you think that is the case, then grab that question, and remember I said you want to be seeing 2 or 3 individual plastic surgeons before you go ahead with surgery, and put that question to those individual surgeons. If someone asks me a question, and as I said, I want to be open and honest and transparent, so I just give them a straight out no, or yeah, good point, it's equivocal. So for example, fat grafting is one of those operations which is in the middle, in that even in very good hands and even in the very best of hands, we would only ever get a survival of somewhere between 45-50%. So anyone who says to you, I do fat grafting, you only need one operation and it will transform you and you'll go from here to here, is just lying. That's not the facts. We also know that because you lose 50%, you're going to need 2 or 3 or 4 operations. We also know that the fat is taken up in an unpredictable way. So that is that it's not going to be uniform or even. So again, be careful of the surgeon who is promoting this as the panacea when you want a surgeon who says, yeah, we can do fat grafting. Do you do fat grafting? Yes. I mean, for example, in breast reconstruction, one of my areas, we would use fat grafting 100% of the time. So we use it all the time. In breast augmentation, we use it close to 60-70% of the time for what we call cleavage lines, or to augment the cleavage, because it makes a difference. But it's not the be all and end all. And I suppose that's the other point there, is that what you're looking for is someone to give you some perspective. The other thing we often hear is fat grafting, I want some upper pole fullness. Say I've breastfed 2 or 3 kids, or I've lost weight, and I've been told I can have fat grafting, and what that's going to do is it's going to give me some upper pole fullness. That's simply not backed up by science. The only way you're going to get upper pole fullness is you need a breast implant. Yes. And you need a surgeon, therefore, who says, oh, I can give you upper pole fullness with fat grafting. You need to fact check that. And hopefully if you saw another surgeon, they would say, like I would, that's simply not the case. If you want upper pole fullness, you need an implant. People I underappreciate that almost every image you see in media now is photoshopped. So if we were looking at, say, someone says, look, I'd like to look like Miranda Kerr, then it depends on what Miranda Kerr as a model is advertising. So if she's advertising Victoria's Secret, she's going to be photoshopped up to a D cup. If she's advertising muesli, she's going to be photoshopped down to a B cup. Now, it doesn't mean that the person coming in saying, I want to look like Miranda Kerr, you need to put that in context and say, I want to look like Miranda Kerr when she's doing X or Y, and then we can use that as our target. We use that as our outcome we're trying to achieve. Yeah, so breast implant illness is a triad of three things more often than not, and that is, so it's fogginess in the head, non-specific pain, which could be joint pain or muscle pain, and a lethargy or a lack of energy. And it seems to be manifest in varying degrees, and so one might be higher than the other. There's some other symptoms which can be seem to be associated with that as well. So sometimes people have talked about getting rheumatoid arthritis type symptoms or connective tissue disease type symptoms. The problem we have at the moment is that there's no science that comprehensively and conclusively links breast implants to those symptoms. Although we do know that some patients, when they have their implants removed, about 50% of them notice about a 30 to 40% improvement in those symptoms. It may well be that we know that the psychology of a lot of different things is fundamental to how we behave and the outcomes we achieve. You only have to watch my football team, Melbourne, play football, and they're up by 2 or 3 goals and there's 10 minutes to go before the final siren. How could they possibly lose? And yet the psychology of the opposite team is such that they overwhelm and then end up beating my team reliably. Or you watch a tennis player that's up 3 sets and has 1 point to win the match and then loses in 5. So psychology is fundamental to us as human beings and how we behave. And so, yes, it may have part of its basis in psychology, but that's not to downplay it and say it doesn't exist or it's not important. Yeah. I suppose the answer to breast implant illness is to understand that the science at the moment still hasn't provided us with an answer. So there's 2 big studies. The 2 big studies, one that came out of California, and that was a double-blind match study of over 200,000 people. And another one in Denmark. So in Denmark, they have a nationalised health service, so you have to disclose everything. And they looked at, again, at a double-blind 2 groups. What I mean by that is they looked at, in the Denmark study, they looked at just under 100,000 patients who had implants and 100,000 patients who didn't have implants, and then looked at the incidence of lethargy, fogginess, joint pain, connective tissue diseases, rheumatoid arthritis and so forth, and found that they're exactly the same in both groups. So from a scientific point of view, we would say we can't see that breast implants cause these symptoms, but it could be that they're associated, but we're not quite sure why. With breast implants, there's maybe divided into 2 things. So there's the complications that you would see with any operation. So it's operation, the risks of the operation with any operation. So that's the risks associated with the anaesthesia. So you want to make sure it's a general anaesthetic delivered by an accredited specialist anaesthetist, not under local anaesthetic with sedation, as we saw, for example, in Sydney, where those people ended up having cardiac complications and heart attacks and almost died because there was no proper anaesthesia being followed. So if you speak to your surgeon and they're a specialist plastic surgeon, they will be utilising a specialist anaesthetist, and you're going to have that done, that procedure, that breast augmentation performed in an accredited licensed facility. So all of those things that are avoidable should be minimised, and in most cases close to, we would hope, less than under 0.1%. We want that to be super, super low. And then specific to breast augmentation, we think that almost all of the complications are related to infection or contamination of that implant at the time of surgery. So people who, even if they have a textured implant, if we can ensure that that textured implant is inserted in a completely sterile, aseptic manner, then when we talked about that rare form of blood cancer, if we follow those protocols and insert the implant in a very sterile manner, we found that there's just, to date, no reported incidence of this rare. So the 14-point plan is just a series of steps which we've been able to identify. Each time we add one of those steps in, we lower the complication rate and lower the risk. Any surgical operation has a series of risks which are part of any surgical procedure, but most of those can be eliminated by having a proper anaesthetist and having that surgery performed in a licensed accredited facility. And if you're seeing a specialist surgeon, that's what's going to happen more often than not. With specific regard to breast implants, interestingly, we found that most of the complications can be traced back to contamination or infection of that implant at the time of surgery. So, for example, we talked before about textured implants and this rare form of cancer called anaplastic large cell lymphoma. We found that if we can minimise or eliminate that infection or contamination of that implant, there's no incidence of anaplastic large cell lymphoma in those subsequent patients. So if you have a textured implant, for you to develop this rare form of cancer, we know that most of the complications we see with breast implants specifically can be traced back to two things. One is infection of the implant at the time of insertion, and that if we can minimise the chance of that implant being infected, things like ALCL, which we talked about before, or capsular contracture can be minimised, even if you're using a textured device. And the reason why that's important is because you might have been aware, but there's been a strong shift away from textured implants to smooth implants, particularly in the last 12-18 months. So that whereas last year we used about 87% of all implants inserted into as part of breast augmentation and breast reconstruction were textured, in 2020, 2021, I think it's probably going to be less than 5 to 10%. And that's predominantly because of this ALCL. The problem we have is that a smooth implant is much more sensitive and much more susceptible to movement if the patients move or exercise too forcefully in that early post-operative period. So we are seeing almost an epidemic of patients presenting after having smooth implants inserted with the implants dropping down and out. So you get a wider gap and the implant's not where the surgeon put it at the time of surgery. So you need to be aware that if you are choosing one of these newer smooth type of implants, that you must be super careful in your exercise regime for that first 3 to 4 months after you have the surgery performed. But we know the incidence of breast cancer is somewhere around 1 in 8. So, and remember we talked about we're not going to, if you have an implant, we're not going to let you have a mammogram. So if you have an implant and you're in your late 30s, say you've breastfed and you're looking at reconstructing or reinflating or revolumizing your breast after breastfeeding, and you're 35. So we know that we're going to need to look at your breasts on at least in a biannual, so every 2 years, to make sure you don't develop breast cancer. And we know we can't give you a mammogram, so we're going to have to give you an MRI scan. So if we're giving you an MRI scan, then what that means is that in some ways we can monitor and keep an eye on your breast very, very closely. So the argument for choosing a smooth implant over a textured implant becomes less clear-cut. And it may well be that you say, actually I'd like a teardrop implant. You can only get a teardrop implant in a textured device. And if we put that teardrop textured implant in an aseptic technique using what we call a 14-point plan, that's where we do 14 individual steps to almost eliminate the chance of infection of that implant, then we can get the risks that we talked about of ALCL, but of capsular contracture and things like that, down to almost zero. We know that rare form of blood cancer, the ALCL, most commonly presents with either a lump or a swelling. So one of your breasts is different to the other. So there's clinical palpation is important, but there's no doubt becoming increasingly clear that keeping an eye on your breast after you have an implant with regular MRI scans, particularly after a textured implant, is becoming a critical part of our surveillance. So almost invariably people have an image at the back of their mind of what they would perceive to be their perfect or their ideal breast. And often we find that that image has been long lasting, has been with them for a long time. So if we maybe divide the groups of patients seeing me into two broad groups, that is, we see the people who have an image of what their perfect breast looks like, but for whatever reason they're going through puberty and as they developed, their breasts never developed to an extent that they achieved what they always thought they were going to achieve or wanted to achieve. And so these would be people in their late teens, early 20s, but sometimes later, but who are saying, look, my breasts have developed, but they're not quite what I wanted. Now that could be something as that the breasts aren't quite big enough as what they wanted. It could be that one breast is bigger than the other, that breasts are asymmetrical. And they're saying, well, can we make my breast more even? And so they would come in normally with a very clear idea about where they want to achieve. And their surgery, because they're young and fit and healthy, tends to be a little bit more straightforward in that often their breast is smaller, so an A or a B cup, and the ligaments and the soft tissue still have some elasticity, and that means therefore that the result that we achieve is going to be much more predictable and reliable. The second group of the patients are the patients that I suppose I see a lot of who've had surgery somewhere else or have been to see someone and everyone's told them that the operation is not straightforward and is difficult. And they're the patients who, for whatever reason, their breast has changed and the ligamentous and the elasticity within their breast has decreased, and the elasticity within their breast and soft tissue has decreased, and it means their breast is saggy or is deflated, or their nipple position has dropped, or they've lost volume in the upper part of their breast. And in those patients, it really is a very specialised, in that if you try and treat that group of patients in the same way as you treat the young 22 or 23-year-old, almost invariably you'll end up with a poor aesthetic outcome and one which doesn't give the patient what they're expecting. And they're the group of patients who we see usually for their second or third operation, having had multiple operations with someone else who didn't quite understand what they need to do. It may mean that we need to use a different type of implant. So we talked about textured teardrop implants, and if the nipple position is borderline, it may well be that that's what we can do, and that's all we need to do to get the right result. It may mean that we need to perform a breast lift or a mastopexy, where we reposition the nipple within the breast itself. It may mean that we need to do some other things inside the breast to try and support and reposition the ligamentous structures of the breast. So that second group is definitely a sub-specialisation or subgroup of breast augmentation or breast reconstruction surgery. After breastfeeding, characteristically, you get three things. You get a drooping or a sag of the breast. You get the nipple position dropping to the bottom part of the breast, and you lose volume in the upper pole. And almost in all of those patients, we need to both revolumize the breast, that means using some sort of an implant, and then repositioning and reshaping the breast, which is a breast lift or a breast mastopexy. Now, if there's some asymmetry, if one breast is slightly bigger than the other, at the same time, we can also reduce the volume of the breast if we need to make sure the breasts are both the same. So again, it's a subspecialised part of breast surgery, but the results are predictable and in the right hands can be relatively easily achieved. Interestingly, that surgery is not particularly painful, not particularly sore, and most people find they can be back inside work in 2 to 3 weeks. It depends on where the position of the nipple is in relationship to what we call the inframammary fold. That's the fold on the bottom part of your breast where your breast meets the chest wall. So if your nipple is sitting at or above that fold, we usually can achieve a very satisfactory result without needing to do a breast lift. As soon as your nipple has dropped below that fold, then what we need to do is reposition the nipple and reshape the breast back to how it was before children, and that means performing some sort of a breast lift. So it comes back to where your nipple is sitting in relationship to your breast. There was a couple of other studies which have shown that most people, as in 98–99% of people, will call an ideal position of the nipple is about 45% of the breast tissue is above the nipple and 55% is below. So what we're saying there is that in an ideal world, we'd want to try and have the nipple in the centre of your breast, but in fact, if we want to be really specific, just slightly into the upper part of the breast. Where we see most often people being unhappy is people have had a breast implant, so their breast has got bigger, but the nipple position is where it was before. So the nipple is sitting in the lower part of the breast, might be 80% above and 20% below. And it doesn't really matter what you do in terms of implant or massage or anything else like that. You need to reposition the nipple. That means you need to have a breast lift. Yeah. So so it's interesting with the newer techniques. So as we know a bit more about blood supply to the breast and how to perform these operations more safely, you can breastfeed after breast augmentation without any problem at all. Even if you've had an ultrasound or a scan and someone has said, oh, we're concerned that your implant might be ruptured, you can still breastfeed. And also with the newer techniques, with breast reduction, we don't need to remove the nipple from the breast anymore. We always leave it attached to the underlying breast tissue, and it means that you can still breastfeed after having a breast reduction. There's two things there. One is about the responsibility of the surgeon to be honest and to the patient and to be as clear and as ethical as they possibly can. But the second thing is that it's really important that the patient is very clear and open with the surgeon, because there are some things that will make a big difference in terms of the outcome. So we talked before about elasticity of tissue, and we talked about outcome and longevity of result. And remember, we said that if the person is in their mid to early 20s, more often than not, the elasticity in their chest and their breast is very springy, and so they get a long result. But if that person has lost, or their weight has fluctuated significantly, so they've gone up and down by say 20 or 30 kilograms, then the elasticity in their breast and their soft tissues will be dramatically decreased. And what that means is that whilst they may not be apparent when you look at your breast, nonetheless the elasticity within the tissues has been damaged, and it means that after we do a breast implant or a breast reduction, we're going to get some sag, we're going to get some droop coming back into that procedure because the tissue has been damaged. So weight loss is critically important. So if your weight has fluctuated or lost, that's really important. We know that smoking, for example, dramatically impacts upon the capacity of the body to heal. And so if you're a smoker, it's really important that you tell your surgeon you are a smoker, and he would tell you, but it's also critically important that you follow, that you stop smoking at least 14 days before surgery, and you don't smoke for 6 weeks after surgery, just so that we can get the best result, the wounds can heal, and we don't end up with wound breakdown or wound healing. If the surgeon says, I need you to rest and take it gently and quietly, he means you need to rest and take it gently and quietly. Don't go back to the gym, don't go back to work. Do follow his advice. Do listen to what he's trying to say. At the end of the day, because the surgeon, I would hope you've seen, has done this for a long time, and in his own mind, he's worked out a program, a post-operative recovery schedule that provides him with his surgical techniques the best outcome for his patients. And so it's really important that you listen to what he's asking you to do and you follow his advice. We've learned, remember we talked before about infection control and things like that, and we've worked out that the old incisions that we used to use, maybe even just 5-6 years ago, that is armpits, incision sites, or around the nipple, are associated with a significantly increased risk of infection and contamination of the implant. So we just don't use those incision sites anymore. So 99% of people having a breast augmentation would have an incision just underneath the breast in the inframammary fold. That incision, because we've got lighted retractors and special surgical instruments now, doesn't need to be any longer than 4 centimetres long. We talked about breast reduction surgery. With newer techniques, we don't need to do what's called a free nipple graft, where we take the nipple off. We can leave the nipple attached. And in most cases, we can do the surgery through what we call a lollipop or a circumvertical incision. That means it's simply an incision around the nipple and vertically down. And unless you're having a very large reduction, we don't need to include that very long transverse scar that was commonplace in certain breast reduction surgery when I was training how to do the surgical procedure. With modern techniques and with better instrumentation, we can make the scars significantly shorter, and we can make them much less obvious. We still need to produce a scar, and we've also had some advances there as well. So we've learnt, for example, that in much the same way that if you break your leg, the bone will heal better if you splint it and immobilise it. And the same thing we're going to try and do with scars. So we would tape all of our scars religiously. Initial evidence showed it's for 2 weeks, then 6 weeks. latest studies have shown we need to tape our scars for somewhere between 3 and 4 months if we can, and that gives us the best opportunity to have a fine line scar. So in our practice, we just simply use a brown micropore tape that the patients would leave on their scars for a week at a time, 5-6 days at a time. They can still shower with that tape. You just simply towel it dry afterwards. Just leave that tape applied to the wound. What it's doing is splinting the two edges of the wound together and minimising any stress or strain on the scar and giving us the best results. So with our practice, we keep you in hospital overnight. We do that for 3 reasons. One, remember we talked about infection being the thing that we really want to avoid. So if I keep you in hospital overnight, I can give you intravenous antibiotics for 24 hours after surgery, and we know that that's the critical time for infection prevention. So I can give you high-dose antibiotics intravenously. The second thing is that I can monitor you. We know that if something's going to go wrong, more often than not it goes wrong in that first 24 hours. And I want to be around where you have your surgery and where you're recovered is 1 floor above my rooms. So it means that I'm on site from very early in the morning to very late at night around that operative period. So it means I can keep an eye on you, make sure things are okay. And then finally, and most importantly, it means that you've got someone looking after you. So you've got someone providing you with meals. You've got someone helping you get in and out of bed. You've got someone looking at your wounds. You've got someone ensuring that you're sleeping okay and making sure that you don't have any pain, and that any pain medication that needs to be delivered, they can do for you. So it just sets you up for the best way to start your recovery process. Almost all of the operations that we do involve a minimum of somewhere between 2 to 2.5 weeks away from full-time work. And the reason for that is 2 things. One is that we want you resting and taking it gently and quietly. But the second thing is, after any form of an anaesthetic and surgical procedure, your concentration span is going to drop back. So you're going to feel you're okay, but your stamina, your capacity to concentrate for more than about 2 or 3 hours is going to be significantly compromised. So if you want to work from home in that first 2 weeks on a computer or paperwork or bookwork and things like that, allocate maybe the first part of the morning to do your computer work, and then take the rest of the day off. And then what I advocate for my patients is plan on having an afternoon nap or siesta every day for that first 2 weeks. That just gives your body time to heal, time to rest, and time to recover. Fat transfer is a relatively new and emerging technology, and it's been one of those things that I think has had a bit of a checkered past. And initially it was promised as being the answer to everything, the ants pants. And we've found that in fact that's not the case. So there's 2 things about fat transfer you need to be aware of. One is that you're going to lose 50% of anything you put in, and secondly there can be some unpredictability in how it's taken up or where it resorbs. And so more often than not you're going to need to have 2 individual procedures. But it has completely revolutionised, for example, people who are born with pigeon chest, where they have a cavity or a depression in the central part of the chest. These are often young boys, so 16, 17, 18, incredibly embarrassed by it, often wear t-shirts all the time, and very rarely would go bare-chested. Now in the past, the only way to fix that would be what we call a NUS procedures, which is a big major cardiothoracic procedure, big operation, hospitalisation and so forth. Fat transfer has allowed us to treat these young lads with 2 small operations, almost done as under some local anaesthetic and some sedation, very minimal recovery and transformative, just completely smooths out their chest. Yes, and increasingly we would use fat transfer as an adjunct in breast augmentation and breast reconstruction. The reason what we found there is that it's very good at smoothing out edges or smoothing out contour irregularities. So in breast reconstruction it would be used 100% of the time now for all of us who do a lot of breast reconstruction. We're just part of our routine. So the only thing you need to be aware of is the fat has memory. So if you take the fat from your tummy or from your bottom and you put on weight, wherever we put the fat into will also put on weight. So that we would therefore tend to use areas where there's less fluctuation. So a common area would be at the medial side or the inside of your knee. There's often a little fat pad there, and that doesn't tend to change very much when people's weight goes up and down. So that's really helpful for, say, in breast augmentation, where we would use it routinely now to, we'll use the term cleavage lines, but to augment or enhance someone's cleavage, particularly if their breasts are quite far apart. we can actually bring or give the illusion a much narrower cleavage with fat transfer. So a smoother finish, and also gives the person more fullness in their cleavage. And we'd be using that now probably 50–60% of the time when we do breast augmentation. So abdominoplasty essentially is two things. One is removing any excess tissue from the lower abdomen, and that can be either after pregnancy or following massive weight loss would be the two classic areas we see there. And then the second thing is repairing or rebuilding and reconstructing the muscles of the lower abdomen. So your six-pack is made up of two muscles called the rectus abdominis muscle, and they're connected in the midline by a ligament. And we know that in pregnancy, the hormone called relaxin, which is integral to childbirth, is released, and that softens the ligaments in your body, and that allows the baby's head to pass through the pelvis at the time of delivery. But it also works on this ligament, and so in the late part of the pregnancy, with the baby sitting low in the abdomen, and with this ligament now being made very lax and soft, this ligament stretches and the muscles separate, and they can separate up to 10, 15, 20 centimetres apart. And what that means is that people after childbirth invariably end up with a wide, what they call rectus divarication, with a pot belly, and they lose their hourglass figure in the lower part of the abdomen. So the muscle component of the abdominoplasty is to bring these two muscles back together again. That means that they're back to where they were before pregnancy, so they're back in the right position. But it means that that lower pot belly or fullness is corrected, and the hourglass figure to the waist is returned. Interestingly, work that's been conducted over the last five years or so has shown that when those muscles are apart, it's associated, not surprising, with a shift in where the organs, so the liver and the bowel and stomach and everything, is sitting within the abdomen, and it sits forward. And because all those organs sit forward, they put pressure on the bladder, and it means that you end up with an incidence of incontinence, particularly stress incontinence. But it also, because everything's sitting forward, it's ended up with altering the dynamics of your lower back. And so patients often complain of lower back pain and lower back ache. So there's a functional component or a physical component to this as well. So abdominoplasty is more than just a cosmetic correction of the lower abdomen. It's also a functional correction of what's happened. Yeah, so the term mummy makeover is an advertising sort of jargon term, and I think we talked before about people advertising and trying to sell a particular product. A mummy makeover is usually made up of two things. It's normally made up of an abdominoplasty and normally some sort of breast work, correct the sagging and drooping that we see after breastfeeding. So, and those two procedures are often combined together because a common factor is this hormone relaxin. So, if you fall pregnant, you invariably produce relaxin, and how much that hormone acts on your body is individual. Some people will have virtually no effect, and that's why they can have two kids and they've got a washboard stomach, and other people can have one child and their tummy can be trashed. We know that relaxin acts on the muscles of the lower abdomen, but also if you've got twins or if you've got a larger baby, you're more susceptible to having this divarication. So the mummy makeover simply refers to a combination of two operations that we see more often than not after pregnancy, but it does involve functional improvement. It does aim to correct physical changes that are a direct result of the pregnancy process. Yeah, so we would see a significant number of women who come in with that combination of breasts which have deflated and dropped after breastfeeding, and then have their muscles which have separated and are finding that they've got back pain or other problems. Yeah, because when they come in, they're saying, look, Mark, I don't want anything special. I just want what I had. You know, like, I've looked after my body. I've tried my best. I go to the gym. I go running. I do yoga. I do Pilates, and I've got this beautiful family. I've got these beautiful children, but they've completely trashed my breasts and my abdomen. And can we do something that takes me back to where I was? I don't necessarily want to be better or different. I just want to be what I was. And along the way, as we talked about, we can do other things that being said, we can certainly improve things if we wanted to. But the most common reason is that people come in is that they found that they have finished their family, they've been at the gym, they've been with the physio, and the physio said, you've got a wide divarication, your muscles are a long way apart here. realistically, I think I've done all I can to try and help your lower abdomen because of the symptoms that you've got, and despite the fact we've done lots of aggressive exercises, we're not getting anywhere, it may be time for you to consider a surgical option. So the most common referral for us for abdominoplasty surgery actually comes from physios who specialise in post-pregnancy or post-maternity rehabilitation, and some patients, their abdomen comes back quickly, easily, and they're the ones we see. How did they possibly do that? But for the majority of women, they get a little bit of improvement, but they can't quite get back to where they were before. And it's usually their physio who said, you should go and speak to Mark or to another specialist plastic surgeon and maybe investigate having this done, because it can be corrected relatively easily, and the recovery process is quite detailed, but it results in taking your abdomen back to where it was before pregnancy. So about a mummy makeover, and I suppose the two things that you need to know about that is that the recovery is quite significantly different. So if we were to do, say, a breast reduction or a breast lift, most patients would say that the pain from that operation is somewhere between maybe a half, maybe a 1 out of 10. They normally feel pretty much back to normal and feel they can do everything. So breast surgery is a very straightforward and predictable recovery. The thing about abdominoplasty is we need to bring these two muscles back together again, and to do that we need to lift the soft tissue and skin from your lower abdomen off the muscles so we can sew them together. And that means that the amount of surgical dissection is roughly about the size of a dinner plate in your lower abdomen. Now your body's going to try and heal that as quickly as it can, and you might know when you've cut yourself, things like that, that normally is completed within about 10 or 15 days. So we need, therefore, for 10 to 15 days after surgery to allow your lower body to be still and allow it to heal. And what that means is you can't do any twisting exercises, and for most people who've got a busy family, they know their whole working day is composed of twisting exercises. So for example, after an abdominoplasty, you can't get in and out of a car. You can't put a seatbelt on. You can't pack and unpack a dishwasher. You can't do vacuuming. You can't make the beds. You can't hang out the washing. All those things that are integral to part of running a busy family household, you need to delegate and offload to someone else. So and that I suppose is the key part of an abdominoplasty recovery. You need to involve your family members and support to give you a hand with getting the kids to and from school, getting the washing done, getting the house and everything ordered. So that might mean getting mum in, getting your mother-in-law in. It might mean going and living with your mum and dad for 2 weeks and leaving your husband to take care of the house by himself. Yeah, so we've dissected that skin and soft tissue off the underlying muscle, and we then need to put that back together again. We do, at time of surgery, we put sutures which hold everything in place. I personally add in drains as well, because what we're trying to do is minimise any fluid collecting in between those two layers. And those drains would normally stay in somewhere between a week and 10 days. And then after we remove those drains, I would then put you into a compression garment, which we would supply. And then following that, probably for a good 3 months after surgery, you need some sort of compression tights or garment to give you some support. So there's lots of commercial manufacturing, there's lots of commercial fitness makers, so Skins make one, 2XU make one. So those sort of garments that give you some compression, you'll find also are very helpful in that early post-operative period. Since 1998, it was my first trip to Vietnam. So Interplast is a not-for-profit aid organisation. It was formed back in the 1970s with a collaboration between the Royal Australasian College of Surgeons, Plastic Surgeons and Rotary. And what we aim to do is a group of surgeons, anaesthetists and nurses would get together, so normally a team of about 5 or 6, and we would travel to a hospital in the Asia Pacific area and then would provide surgery to the village of that community free of charge over a 2-week period. And we'd operate on a broad spectrum of patients. Almost invariably, these people don't otherwise have access to medical care. So it's not uncommon for us to see a 14 or 15-year-old young boy with a cleft lip and palate that he has simply had no opportunity to have repaired. And in an operation that takes somewhere between 45 minutes and an hour, we can put his lip back together again and give him a completely different life. It's very rewarding work, and it makes a life-changing difference. Living in Australia, we probably underestimate the availability of freely and readily available power and heating. And even in the relatively humid and temperate areas of the Pacific, so for example, we're recently up in Papua New Guinea, which can be 30 degrees during the day, but particularly in the highlands can drop to close to 0 at night. And so these villages don't have any access to heating, and their only way of keeping warm is to have a fire inside their hut, a fire inside their house, which is often on the bare floor. And not surprisingly, the young kids who are 5, 6, 7 try and get as close to the fire as they possibly can, unaware of the danger that it imposes. And so we would quite frequently see young kids who are 5 or 6 or 7 sustaining burns, which are often full thickness, that is, they burn all the way through the skin, on their limbs or arms, or sometimes even their faces. And the problem with young kids is that that burn does not move, so that burn becomes fixed in its size and its extent, and so while the rest of their body continues to grow, this burn stays as it is, holding those 2 bits of tissue to which it's attached in the same location. So if you have a burn across your elbow or across your knee or across your hip, you're going to find that progressively your elbow is fixed and your hand starts being stuck to your shoulder, or your knee is fixed and your ankle starts getting stuck to your thigh, or if it's in your groin, that your knee starts getting stuck to your abdomen. And the problem with that is that then all of a sudden, one, you can't move around as freely as you could before, but more importantly for the village and for the community, as a young adolescent and then a young man or a young woman, you then become dependent on the community rather than a provider for the community. And so if we can correct and fix those burns, which often can be done with a relatively simple and straightforward operation, not only do we change that person's life, but we also dramatically improve the capacity of the village and the community to look after themselves. So Woodrow and I were up in far northern Papua New Guinea 2.5 years ago in a small place called Bethany, which is right on the junction between Indonesia and Papua New Guinea. And we were there on our second day, and a young girl who was 3 years old came out of the highlands, and her knee was stuck to her chest, and she sustained a burn at the age of 6 months. And that burn had effectively fused her, the skin around her hip, such that her knee and thigh was welded onto her lower abdomen. It meant that she was not able to move around by herself, and her mum or her dad had to carry her in their arms to move her around. And she's in the highlands of Papua New Guinea, so it's not flat, there's lots of hills and things. So it meant that not only was she unable to move around, but it also necessitated that her mum or her dad had to constantly care for her. And what we did is we were able to take her to the operating theatre, give her an anaesthetic, and then release that scar and perform a skin graft in such a way that we were able to completely straighten out her hip. And at the end of the surgery, she was walking again. And I suppose that's the thing that makes the real difference to these Interplast trips and these aid trips, in that they are transformative. You take someone who is otherwise unable to get this care, and if we had not been there and been able to provide that surgery for her, she would have been condemned to that lifestyle for the rest of her life. Whereas now we've set her off on a completely different journey and a completely different lifestyle. MAPAC, or the Melbourne Advanced Facial Anatomy course, is a course run in Melbourne by a group of plastic surgeons who have a special interest in facial anatomy and in facelifting surgical techniques. It was started by Brian Mendelsohn back in 2000 in association with myself and Simon Bernard But we have also been able to, and have been fortunate to have, other surgeons such as Keith Mutimer and Peter Callan from Melbourne, but also surgeons from interstate, from Sydney, from Brisbane, from Perth, and then surgeons from America, South America and Europe join us. What we're trying to do is provide a sound anatomical basis for the techniques we currently employ in facelifting and facial rejuvenation. It's helped enormously, not only with surgical facelifting, but also non-surgical facelifting. Most of you would know of face fillers, but also Botox, and also be aware of some of the complications that can occur when those products are used by people who don't know their anatomy. So this course is run twice a year, both in Australia and in America, and aims to teach plastic surgeons on the anatomy of the face and how to get better outcome, but also how to avoid some of those complications such as after fillers, such as skin necrosis, or, as been unfortunately reported recently, blindness after fillers. So we're trying to educate people, train them up and teach them so that they can provide more comprehensive care which is based on a sound knowledge of anatomy, but also provide a better outcome, less downtime, and avoiding any of the complications which can otherwise be seen. Yeah, so anatomy is one of the things that I love. I'm a professor of surgery at the University of Melbourne and closely associated with the University of Anatomy. And we've been doing research into anatomy and how that can help surgical technique for over 20 years. One of the initial things that we were pioneering is in breast reconstruction using microsurgery. And in the early 2010, 2012, the way in which we did that surgery was difficult because we didn't quite know where all the blood vessels were or how big they were going to be. And our unit pioneered a thing called CT angiography, which is where we use a CT scan to look at the blood supply of the lower abdomen. And it means that we can allow the surgeon a roadmap as to how to do their operation. So the operation is much quicker, much more reliable, much less morbidity, and significantly lower rates of skin necrosis and things going wrong. So Melbourne really is, I suppose, with the Melbourne Advanced Facial Anatomy course and then with the Department of Anatomy at the University of Melbourne, at the forefront of anatomical research in plastic surgery. And that's reflected in the number of awards that the Melbourne plastic surgeons have been given by international societies, both in Europe, America, UK and South America. The most important thing to know about Botox and fillers is they're not risk-free, and it's critically important that you seek out someone who's performing that procedure for you, who is skilled and trained. With Botox, we know that it paralyzes muscles. It damages the interface between the nerve and the muscle temporarily, and that means that even if we get the Botox in the wrong spot, in most cases it will recover inside 3 months. So a drooping eyelid or drooping brow, even if it's done badly, in most cases can recover. Where fillers are concerned, however, it's a completely different scenario. We know that the newer fillers, which are made up of a product called hyaluronic acid, that's the same material that we see inside joints, inside tendons, it's inside your skin, it's inside your eye. So it's a very common product which is naturally made. We know that that product, if it's inside the soft tissue, outside of blood vessels, it's incredibly well tolerated. And that's why it's, I suppose, almost ubiquitous now. We don't use the collagen products which we used to use 5 or 6 years ago. And almost every filler contains hyaluronic acid. The problem with HA though is that if it gets inside the blood vessels, it's incredibly irritant. If it gets into the blood vessels and then goes to another part of the body, which it will do, it can cause skin necrosis or tissue death at a site away from where it was injected. So we've had patients who have had filler injected into their lip by someone who didn't know their anatomy, and then have turned up 2 or 3 days later with the tip of their nose dying, or a large patch of their forehead dying. The thing which is even more concerning is that if the hyaluronic product is injected into an artery and the person doesn't know their anatomy, it can travel along the facial artery inside the face and can access the arterial circulation of the eye, where it causes the same inflammatory process and the person can go blind. And in fact, that happened just 2 months ago, where a young 23-year-old had filler injected in a supermarket. The person injecting it didn't know their anatomy, injected the filler into the facial artery, and the young girl was rendered blind instantaneously and permanently. To date, there's been no mechanism by which we can reverse that blindness. There are some studies coming out of China where it seems that radiological intervention may be of help, but that needs to be implemented within an hour after the blindness occurring. It underpins, though, that if you are having filler, you must see someone who knows what they're doing. You must see someone who knows their anatomy, and you must see someone who knows how to treat the complications should they occur, and to know what they look like. What we see in our practice is people who had filler yesterday or the day before and turn up to see us, and they might have spoken to the clinic where they had, or the supermarket beauty salon where they had their filler injected, and they'd rung that salon 2 or 3 times, but the salon were unaware that your skin could die or you could go blind after fillers, and simply dismissed the person went away, when in fact, had treatment been implemented earlier, could have completely corrected those skin complications. Yeah, so facial rejuvenation is a combination almost invariably of 2 things. So sun damage and your genetics. So we obviously would be avoiding things which we know age your face. So smoking, we would get you to stop, and we would try and keep your weight relatively stable. If you lose a lot of weight, you're going to find that your face prematurely ages. But taking those 2 groups out, we know that if you can avoid the sun UV radiation as much as possible, that will have enormous benefit on your skin over the longer term. We know that your skin is dependent upon vitamins A, C, E, and vitamin B3. And so if you can supplement your skin with those vitamins, you will also find that there is an improvement. So I suppose what I'm trying to say is that even from a young age, there are things that you can do which will help you age better. So stay out of the sun, don't smoke, keep your weight relatively stable, and maybe look at some moisturizing skincare product which contains those vitamins A, C, E and vitamin B3. Be careful of the product which is costing a lot of money but doesn't seem to have any of those products. So it's really important you read the label. There's lots of really good products on the market, but there are others which cost hundreds and hundreds and hundreds of dollars and do absolutely no good at all. If you're in that moving on then, and if you're saying, look, actually my face is aged and maybe I'd like to do something, because we live in Australia, one of the most effective ways of altering the sun damage and making you look rejuvenated and younger is to take away some of that sun damage, some sort of resurfacing procedure. So that could be an acid peel, that could be some sort of an erbium or carbon dioxide laser. What we use is a fractionated laser called Fraxel, which does the same thing. The advantage of Fraxel that we like it is because the downtime is much less. It's not a week or 10 days, it's 2 to 3 days. But if you're someone who is my complexion, so Caucasian, English, Irish, Scottish background, who spend a lot of time in the Australian sun, you'll find that that will make a tremendous difference to your skin. The other thing we talked about was that as we age, we find that our skin drops and we lose volume from the upper part of our face, and it tends to be redistributed to the bottom part of our face. So in those patients presenting, combining some sort of resurfacing procedure with revolumizing the upper part of the face, you'll also find that gives you a very subtle, understated rejuvenation of your face without people being to spot that you've had anything done, which I think is the key. You want someone looking younger and more youthful, but not to the extent that people say, oh, you've clearly had work done. That's not what we're aiming for. We're simply aiming to refresh, and we can do that now with minimal downtime and very safely with some of these newer products that are on the market. As we age, we have a combination of sun damage and also of loss of volumization in your face and droop and sag. And at some stage, the amount of droop or sag, the amount of retightening that is required, is not able to be achieved by simply revolumizing the face. And in those situations, then we need to surgically tighten the skin. And I suppose that's one of the things which frustrates me, is that people clearly needed surgery because the amount of laxity and the amount of droop is never ever going to be taken up by fillers. And people blow up people's face using lots of revolumization procedures, and it just makes people look overweight and very full and very bloated. And what they needed was a surgical retightening of the skin and soft tissue. We talked before about MAFAC, the course that we run here in Melbourne, and what we're trying to do there is show surgeons, plastic surgeons, how we can do this retightening procedure with minimal downtime, very safely and very predictably. And most of the new modern lifting or resuspending techniques can be done with virtually no bruising. Most people can be back at work inside 10 days to 2 weeks. Very effective and very predictable way of tightening the skin. Yeah, and it's much longer lasting than the previous techniques. We all have been aware of the old technique, which was getting the skin and pulling the skin tight. And the problem with that is you end up with a super tight, windswept looking face, which looks very artificial and very unnatural. These newer techniques are designed that we simply target the jowl or the nasolabial fold and tighten those preferentially, and leaving the rest of the skin effectively untouched. And it means that the result you achieve is very natural, very understated, and in many cases is unnoticeable. So in the initial stages, keeping out of the sun and using products which contain those vitamins A, C and E and vitamin 3 will make a big difference. If you get to the stage where you're looking at maybe doing something a little bit more invasive, maybe look at maybe using some fillers to revolumize your upper part of your face and some sort of a resurfacing. And then at some stage, you may never get there, but at some stage it may be worthwhile, if things progress, looking at some type of retightening, relifting of your skin and soft tissue to put things back to where they used to be.